this topic. Does anyone have any questions related to yesterday's session? So I would assume then that's no questions. Okay. So as we did with yesterday, after each section, I will stop and please let me know if you have any questions. Again, I tried to keep things as simple as possible, but also it should be with enough details that you can manage this with any installation relatively easily. Okay, and the tools will be available. I'll show them to you at the end. So reference range verification. It should be simple, but it often leads to some confusion, especially on the customer side. What do I mean with that? And let me turn on my camera. Yes. So reference ranges officially in CLSI, they are preferably called reference intervals. Okay, so reference interval, reference ranges as people normally call them. Normally, it doesn't make much of a difference, but CLSI prefers that you use reference intervals. That's just for you to know. Now, the point of reference range verification, a reference range, as you know, is the range of results that if the patient result is within is considered to be normal. And we need to verify these reference ranges for a simple reason. It's because reference ranges, if you get them from the manufacturers, get answered. If you get them from literature, if you get them from another lab, maybe they do not work very well for your population. So you may be classifying a patient as normal, whereas this patient is not normal. So it's very important that the reference range that the lab is using is actually properly made. Otherwise, you'll be misclassifying your patients. And obviously, this is not something good. Okay, so we have either verifying a reference range, meaning there is an existing range. I will just verify if it's good, if it's a good fit for my population. And there is establishing a new reference range, means I do not have a reference range to use, or I don't want to use what exists. I want to calculate a new range from scratch using my own population. Now, establishment is definitely the better option because it will be made from results from your population. However, establishing is more expensive, it's more technical, it's more difficult, it's not always possible. So most labs, they will go with the easy choice, which is verification. Means I will take a range from the manufacturer, from another lab, from another whatever, someone already made this range, and I will verify if it fits my population. Okay, so this is what verification means. There are different types of verification also. So verification is not just one thing. There are different types of verification, and there is one of the simplest of them. We'll talk about it, which is what most labs would be following. Okay. This is stuff we'll speak about it later on. Now, briefly, as you know, when I'm calculating a reference range usually represents people who are healthy, who are normal, who do not have any diseases. So that follows that it is normally healthy people that are selected for this range calculation. I would not be, for example, choosing cancer patients to calculate my reference ranges because cancer patients do not represent a healthy population. I cannot conceivably use unhealthy people to calculate reference ranges that will tell me this result is healthy. Okay, so this thing is quite obvious. No need to discuss it any further. And one point that labs often miss is that the ranges have to be calculated from the population that you work with. For example, some parameters are affected by ethnicity. So you cannot, for example, be working in France and you get a range that is calculated in Botswana, for example. Okay, so this can be different from parameter to parameter, but it's very important that if the lab wants to verify or even establish the ranges, then they must use their own population. And their own population, I mean the patients, not the staff, not the nurses, not the technicians. Okay, it must be the patient population that the lab works with. This is absolutely crucial. And a lot of labs, they think, oh, okay, I will just collect some samples from my staff, make it easy. Okay, fine, but the range you are verifying probably is not accurate for your patients. Okay. Now, you know, some parameters are age specific or gender specific or ethnicity specific. This is something that's obvious, of course. We'll not dig into it much deeper. This is pretty much the same point as the previous stuff, so I will just skip it. Now, before we get into the technicalities of reference range verifications, you have to know that not all parameters within coagulation have reference ranges, okay? For example, for INR, there is no such a thing as INR verification. For antitin A, unfractionated heparin, low molecular weight heparin, fondaparinux, DOACs, the same thing goes for the bigatran, the chromogenic assay, ECA2 kit. These are not reference ranges, okay? So for low molecular weight heparin, for example, one of the more common types is called enoxaparin. It's a low molecular weight heparin. It's an anticoagulant. The 0.6 to 1.0 IU per ml is not a reference range. This is something called the therapeutic range, okay? So as you have noticed, the INR, the low molecular weight heparin, UFH, DOACs, these are all anticoagulants. Anticoagulants do not have reference ranges because simply they do not exist normally in the blood. Plus, the ranges that are dedicated for them are called therapeutic ranges. And therapeutic ranges are not calculated from the patient population like you normally would do with the PT second reference range. These ranges are based on clinical trials that are conducted to see how effective is this particular range of measurements for managing the patient, that the patient does not bleed too much, that the patient does not have thrombosis. So these ranges with anticoagulants are not reference ranges. You cannot verify them in the lab, okay? If you want to verify them in the lab, this will be extremely expensive and difficult and time consuming. That's why it's not practical to do this thing, okay? The existing guidelines know it, and they do not ask you to verify them. So you use them as they are. Where do they come? Sometimes the manufacturer of the kit will provide it to you, but often it comes from someone who done the clinical trial for this medication to see how effective it is in managing the patient's condition, okay? I will not detail more on this point. I hope it's clear. Before I proceed, because this is a very important distinction, does anyone have a question about this point? Because it tends to be confusing in the beginning. Then I would assume that it's clear. And by the way, yes, I forgot to mention, D-dye cutoff, the 0.5 microgram per ml or 500 nanogram per ml, same thing, different unit. The same concept applies to the cutoff of the dimer. You cannot verify it. The customer cannot just come to you and say, I don't like this 0.5 microgram. I want to make it 0.4 microgram and I will verify on my own. You cannot verify it like a normal PT or APTT reference range. It's very complicated and it's based on a lot of clinical work. Okay, it's not something straightforward, very difficult, very technical, very expensive. So you have done a reference range verification. Before you get into the numbers, you take the result of your work and you go to the lab director or the quality manager and you tell them, oh, reference range verification passed for PT. So this means the range that you chose for PT, good, you can use it for your population. Okay, you can report patient samples, but for APTT, reference range verification failed. A lot of customers, when they hear reference range verification failed, they think that there's a problem with your reagent, with your machine, with your work, whatever it is. Reference range verification failure does not mean a failure on the system part. Most often, reference range verification failure means that the reference range that you have chosen to use in your lab is not compatible with your population. For example, in most of the countries in the Middle East, if you take the reference range of neoptimal that is in the kit insert, it says, I think, 13 point something or 12 point something up to 15.3 seconds. For most countries in the Middle East, 15.3 seconds is a very short or a very low reference range to use for the population. A lot of the labs that calculated their own reference ranges for neoptimal reached 16.1, 16.2 seconds. So this means a lot of normal people who can read 15.4, 15.5, 15.6 seconds, 16 seconds will look abnormal if you use Stago range. So this means Stago range for a lot of people, a lot of populations in the region, they are not compatible, okay? So reference range verification failure here does not mean that your machine has an issue. It simply means that this reference range that you have chosen, Stago's range in this example, does not work well with my population. Then what do? You either look for a different source of reference ranges. Maybe you can go for literature. Maybe you can ask another lab who have established their reference ranges locally, or you can establish your own range if you have really no choice, okay? But remember, reference range verification is generally easier, faster, less costly than establishment, okay? So this point is very important because, again, a lot of customers think that reference range verification failure means that this is a failure on the part of your analyzer. This is often not the case. It's very rare that the analyzer is to blame. And this is something that usually you detect with the QC or with calibration or with something else. You will not have to wait for reference range verification to detect such an issue. So this is an example of a report from EP Evaluator. EP Evaluator is a software that a lot of customers know and are familiar with the reports of. It's a third party. It's not from Stago, so if your customer uses it or not, it doesn't matter. But this is just an example of a report. So we have done a reference range verification of a given reference interval. This is for hemoglobin, for example. So the customer says to you, I want to use this reference range, it's called the proposed, that is 11.5 to 16 grams per deciliter. I want to see if it's compatible with my population or not. So how do we do it? At least I will take 20 patient results that are supposedly normal. Okay, if you look, here are the results down in the experimental results. Then I will check these 20 samples that I collected from my population. Do they fall within this range of 11.5 to 16 grams per liter? Now, the current guidelines tell you very simply, you need at least 90% of the 20 samples, so 90% of the 20 samples to fall within the range for us to consider that the range has been verified. Okay, so you have 10% of the results outside of the range and 90% of the results must be within range. This way, I say my verification pass. If 15% of the results are outside of the range, I would say that the reference verification has failed. I would try to run another 20 samples, total of 40, and then I will calculate again. Do I still have 15% out of range? Then, yeah, this range verification has failed. It's not compatible with my own population. Not an analyzer problem. Okay, so this is the simplest form of reference range verification. I will find a range that I want to use from another lab, from the manufacturer, from literature, I don't care. Okay, and then I will run at least 20 patient results. My own population, the patients I work with, okay, not my staff, not the nurses, not the neighbors, my patients that I work with. 20, then I will see. Did 90% of them or more fall within the range? If yes, I passed. If no, I run another 20. Then I'll check again. Did at least 90% fall within the range? If less than 90% fall within the range, reference range verification has failed. You have to look for another range or try to see what is the issue. Okay. So this is an example of reference range verification that have failed. So the 10% is defined as the maximum acceptable limit, which I just told you about. Where did I get this number? From CLSI. Okay, so 10% of the samples at least, at maximum. So maximum 10% of my patient samples can fall outside of the 80 to 100 range. Okay, this is different parameter. However, my observed outside, the number of samples that were observed outside of this range was 15%. So I would say this reference range verification failed. In this case, CLSI tells you run another 20 samples, so you have a total of 40. With the total of 40, 15% still is the failure rate? If yes, your reference range verification has failed. You say this range is not compatible with your population. You have to look for another one. So any question about reference range verification?
Yes.
Yes,
How
Ibrahim.
about when we use, for example, say we have a lot of historical data? Are we able to use like thousands upon thousands of historical data to get some reference range, or using the reference range transference as you have described?
Okay, see, if you want to do things in retrospect, then there's a way to handle this according to CLSI guidelines. You can do it, you can work with it, provided that you have information that tells you that the patients you have chosen are actually healthy patients who do not have any coagulopathies. Okay, coagulopathies or any pathological condition related to the parameter you're trying to work with, whether it is CBC, chemistry, immune, or whatever. Okay, so if you have these patients and you can calculate your own reference range, establish your own reference range from thousands and thousands, that's excellent, that's great. Okay, a transference comes second to this because establishment, of course, is superior because you are using your own data to calculate your own ranges. You don't have access to such information, okay, which again would be great to have. Then you can do transference. Transference for people who are not familiar with transference, transference is I have another lab that has basically the same analyzer I have, the same population that I have. They have established their own ranges. Okay, so I'll tell them, please give me your ranges because it's the same reagent, the same analyzer, the same population. They have done the establishment already. I will take this range. I will try to verify it with my own population. Okay, so I'm transferring the range from their lab to mine, but I'm verifying it before I use it. Okay, so this is the least thing you can do for reference range verification. It's acceptable, but it's the least you can do. There are better things, but this is the thing that most commonly is used. So did I answer your question, Ibrahim, or you're looking for a different point?
Yeah, you answered. Thanks.
You're welcome. You're welcome. If you want to discuss this in more detail, I can send you the part of CLSI document that answers this question, because there are some minute details that maybe you should know. So detection limits. Now, detection limits, to be quite clear with you, is not something that you would often have to work with, but it's something that often causes confusion because a lot of people are not so familiar with it. Because customers might tell you, for example, I want to calculate these detection limits, LOP, LOD, LOQ. So if you don't know what these things are, you would not know how to answer your customer, and you would not know that they are often not needed for our case. Okay, so I opted to add them, so at least you are just familiar with them. You would know how to explain to the customer that you do not need them and why do you not need them, and what documentation do you have available to use in this case. So CLSI document EP17A2, and there's another one that's a practical form of the document, so to speak, called EP17ED2IG. Okay, these are the two reference documents that I have used to make this part of the presentation. So these ones are your reference, and again, I told you CLSI is the sort of document that generally no one argues with. Okay. Now, what are detection limits? What do I mean with detection limits for a particular test? Now, when I want to measure something, for example, let's say the easiest example to work with is drugs of abuse. Okay, someone, for example, who's working in a lab that wants to detect if the sample that came from someone does contain a certain type of drugs. Okay, now when it comes to drugs, I need to detect very small amounts in the patient's blood or the person's blood. Okay, however, the test might not be able to detect very, very, very tiny amounts. Some tests will be better than other tests in detecting very small amounts. Okay, maybe one test can detect 3 parts per million. Some tests cannot detect anything less than 10 parts per million. Maybe, for example, to take someone to jail, you need to detect at least 5 parts per million. Okay, so these things become very relevant with tests of this type, tests that you need to detect very small amounts of a certain analyte or a certain measurement. Okay, measurement basically is the thing you are measuring without detailing things much more. Okay, so when it comes to detection limits, you will often hear things like sensitivity, analytical sensitivity, diagnostic sensitivity, specificity, limit of detection, LOD, limit of quantification, LOQ. ULAQ is upper limits of quantification. Okay, we will come to all of this. So these terms might look new or bizarre or irrelevant, but you will see they're quite simple. Now, a small distinction. CLSI tells you actually to avoid using the terms sensitivity and specificity interchangeably with LOD, LOQ, upper limit of quantification, and all of this, especially sensitivity. Because a lot of people use sensitivity interchangeably with these. But CLSI says this is not the case because the term sensitivity and the term specificity are used in many different ways that are not very standardized. Okay, so for example, you have analytical sensitivity. How sensitive is the test to a certain measurement? Or diagnostic sensitivity. How good is the test's ability to detect the presence of a disease or a virus or a bacteria? There is negative predictive value. These things can all become very messy and they are not standardized uses. So to clarify, CLSI says we will not use sensitivity, we will not use specificity. When we are describing the detection limits of a test, we use LOD, LOQ, ULOQ. And there is another one called limit of a blank. Okay, so for our use, for this presentation, based on CLSI, we will not talk about sensitivity and specificity. Okay, just to give you a small example. Analytical specificity, okay, is the ability of a test to measure only one thing without measuring the interferences. Because, for example, when you work with the plasma, you do not have only D dimer, you have D dimer, you have albumin, you have a million other things. When we run a D dimer test, we want the D dimer test to measure only D dimer. We don't want it to measure fibrinogen degradation products. We don't want it to measure factor rate. We want it to measure only D dimer. So the ability of the test to measure only the thing it is designed to measure is called analytical specificity. There's a diagnostic specificity, completely different principle or concept. Analytical sensitivity is how sensitive is the test to the change in the presence or concentration of the measurement. For example, when I want to measure again drugs of abuse, okay, for every 10 units of change in the drug concentration, my test changes by a very tiny amount that maybe my machine cannot even measure accurately. So this means the test is not very sensitive. I cannot detect changes in the concentration of the drug, for example, okay, very accurately, which means my test results are not very accurate. Sometimes maybe the drug concentration will change a lot, but my test reaction will change just a little bit. So you will not see a very big change in unit. Okay, this is called poor sensitivity, for example. So this is what analytical sensitivity is, okay? How much your test signal changes proportional to the concentration of the thing you are measuring. So as you can imagine, this is something relevant for things that need to be detected at very low concentration, which is often not the case in coagulation. But it's good to have this information. Again, if the customer asks you, you understand why these things are not needed. So this is what I explained to you and why we will not use these terms and the confusion about them, okay? So CLSI, as I told you, says do not use sensitivity in the context of detection capabilities. We use limit of detection, limit of blank, limit of quantification. So what are these LOD, LOQ, and ULOQ? Now, first of all, LOB, I think I did not add it. Yes, I did not add much of it. Limit of a blank is the point that limit of blank is generally given as a concentration. So anything below the limit of a blank is considered as nothing. There is zero of the thing you are measuring. For example, let's talk about D dimer. If we say the limit of a blank of D dimer means anything below this concentration, there is actually zero D dimer. Maybe the machine is just measuring an interference. It's measuring some background light, for example, okay? So anything below the limit of blank is considered zero. There is nothing, okay? Limit of detection is something that is higher usually than the limit of a blank. So we say the limit of detection, anything below the limit of detection, we can say that the machine can detect if it exists or it does not exist. Anything below the limit of a blank, even if the machine tells you that it exists, we say no, it does not exist. The machine maybe is measuring some stray light, maybe it's measuring some signal from outside, but anything below the limit of a blank, even if the machine gives a measurement, we say nothing. There is no concentration of the analyte. Anything between the LOB and the LOD, the machine can say it exists or it does not exist. Okay, so the limit of detection represents the limit of your analyzer's ability to detect the presence of something or its absence. Okay. Usually higher than the limit of detection, we have something called limit of quantification. Okay. So anything between the limit of detection and limit of quantification, the machine can give you a quantity, not just exists or does not exist. The machine can give you a quantity, but the accuracy of this measurement is very poor. So again, between limit of quantification and limit of detection, I can give you a quantity, not just present or absent, a quantity, but this quantity is not very accurate. Anything above the limit of quantification is part of your analytical measuring range, which you can report with confidence. Okay, so limit of blank, limit of detection, limit of quantification, they are higher amounts of confidence in the measurement I'm getting, to simplify. Okay, how do I calculate them? How do I use them? Usually we do not need to do this in coagulation, and I will specify. Okay, so to reiterate, limit of detection is the minimum detectable concentration. Okay, so as I told you, limit of detection, between it and limit of blank, I can say present or not present. That's all I can do. Can I give a quantity? No. Based on who says we can report like this, CLSI and many other guidelines. Limit of quantification is the minimum concentration at which an analyte, etc., etc., etc. Means, again, between limit of quantification, limit of detection, these results in this range are a rough quantity. They are not very accurate. Okay? Anything above limit of quantification is considered to be accurate and you can report it normally. You will see a table at the end of this presentation that will help you understand this a little better. It's just a summary of what I just said. So limit of quantification sometimes is referred to as lower limit of quantification. Why? Is there an upper limit of quantification? Yes. Upper limit of quantification is the highest point in the AMR. Okay? So lower limit of quantification is the low point. Upper limit of quantification is the highest point in the analytical measuring range, which can be a very large number, obviously. So the upper limit of quantification is the highest point in your analytical measuring range. Lower limit of quantification is the lowest point of your analytical measuring range. Okay? Now, this point, I just left it for you because I told you we'll not discuss sensitivity and specificity, but it's good to understand this point. Okay? Now, this is the point also I mentioned earlier. In coagulation in general, LOB is not relevant. I don't care about measuring tiny amounts, for example, of von Willebrand or tiny amounts of factors. For PT and APTT, these are tests that are reported in second. The concept of LOB does not even apply because I'm not measuring a concentration of something. I'm measuring the activity of my coagulation factors. So it doesn't make sense to use an LOB or an LOD. Okay? It's just that my PT did not clot. That's it. That's all I need to know. I'm not measuring a concentration in this case. So for coagulation, it's almost insignificant to know LOB. It's really insignificant. LOD and LOQ may be relevant in cases such as factor 8, von Willebrand RCO, because it is clinically relevant to have the limit of detection and limit of quantification known for factor 8, because, for example, values below 1% in factor 8 are different from values of 1%. This is a different classification of the patient, and this is a different classification of the patient. This is a different clinical treatment, and this is a different clinical treatment. So for some parameters, it is relevant to know the LOD and the LOQ. For example, in our kit inserts for tests reported in percent, nanogram per ml, microgram per ml, you will have a limit of detection, and you do not have limit of quantification for the max generation. We will have it for the ST hemo generation. Okay? So it is relevant to know LOD, LOQ sometimes for some parameters. For LOB in coagulation in general, it's irrelevant. Okay, because as I told you, it maybe is relevant for very sensitive tests that you need to know very small amounts, like PCR. I need to know if there is any amount of DNA present in the sample, for example. So to give you a small example from our reagents, the dye limit of detection, okay, is 0.27 microgram, which is the lowest point that you can report with this assay. Okay, so in this case, why is it not very relevant for us to verify limit of detection for D-dimer? Because clinically it's not relevant. What is the relevant part of D-dimer assay? The 0.5 microgram per ml cutoff. Okay, so this is all I care about. Is limit of detection relevant for D-di clinically? Absolutely not in this case. If the limit of detection was higher than the cutoff, means the assay is not reporting good results at the cutoff, means clinically we cannot use this test. But for us, we don't have analyzer tests where the limit of detection is above the cutoff or above the limits that we need for the work. Small exception is von Willebrand RCO in our case, because the limit of detection for our assay is 16%. Which is not very accurate for RCO, which is not very good limit of detection for RCO. So this is a bit of a limitation for the von Willebrand RCO. So it's good for you to know that limit of detection is 16%. Below the limit of detection, I cannot report anything. Okay, you will see how to report this with the table at the end of the presentation, or this part of the presentation. So this is the point I mentioned to you. I will not repeat this. This also will be mentioned in the table, so I will not repeat this. This is just clarification for you. So this is the table from CLSI. You have different reporting formats in CLSI. Okay, they tell you can report in this way or you can report in that way. It depends on what the customer wants. So, for example, if the result is less than the limit of a blank, I say that the result is not detected. Even if you get a number, I don't care. As long as it's below the limit of a blank, okay, the result is negative. Does Stago give you limit of a blank? No, because again, general in coagulation is not relevant. Limit of a blank results between limit of a blank and LOD, okay, we say they are detected or absent. That's it. We do not give a quantity. Results between limit of detection and limit of quantification. You have two choices depending on what the customer wants. So either the user can say detected or absent, or they can report less than limit of quantification, or they can report a quantity. They can report a number, not just present absent. They can report a number, but they can mention maybe in the report that the accuracy of this result is not very good. Okay, very high in precision, for example, very high possibility of having a bias. So the user can decide between options A and B here. It's up to them. Finally, if the result is higher than the LOQ, means we are within the analytical measuring range. And as long as we have verified our analytical measuring range, as we said yesterday, our reportable range covers things higher than the LOQ, we report things normal to the patient without any warning, because these are results that should be accurate. Okay, so this is an example with numerical values, just for you to have an idea about how to report things. It's exactly the same as the previous slide, but with numbers and parameter measure and test measurements for clarification. Okay. So this is again the thing I told you that some parameters it's relevant, like factor 8, like von Willebrand, for example. It would be relevant to know the LOD, LOQ. But generally, users would not ask you to do any kind of verification for this. Okay, can be done, but generally users do not ask for it. If they do, then we can do it at that time. Please let me know. I will help you with the documents that you need, but that's something for a different day because often this is not requested. Okay, and we do not have any official documents from Stago for this kind of work. So we may have to create a new Excel sheet or use external tools or use AP Evaluator, whatever is needed. So, any questions about detection limits?
Hi, Mr. Late, how are you? Yes, I have.
Hello, Julius. Yes, please tell me.
Uh, Actually, I have two questions, but I will start with this question with
Mhm.
the low detection limit. I have also one question that the topic which is yesterday, but I need to reserve it later. So I need to start with the
Mm.
detection limit. See,
Yes.
as I understand, as you discussed, you have the EMR. So the EMR,
Mm.
this is the test which is already now the value validated and validated by the Stago, right? Now,
Correct. Yes.
about the LOB and
Mhm.
LOD, which is both if below if the result is LOB, we are releasing as negative, and above it is LOD. Now, my question,
Mhm.
example for PCR or any other test, how many percent the the bias or imprecise if the result is between LOB? Usually, I mean minimum. Usually, what is the percentage of the bias?
I didn't get you. You mean if the result is between LOB and LOD, what is the bias?
Yeah, because see, in LOB, I
Mm.
expect, example, if the result is below the AMR, see, maybe some result, let's say, example only, I will give the number, example 5, but
Mm.
the limit is 6, okay? So when I
Okay.
run this one 5, maybe when I repeat this sample, it will be 1 or it will be 2.
Mhm.
So this is my question between 0 to 5. Usually what are the or what is the bias, like how
Okay.
many percent? The only estimate, at least we know, because I expect that
Mhm.
any result which is LOB, uh,
Mhm.
maybe percent 5, maybe sometimes 0 or maybe sometimes 1.
Yes, yes, I understood your question. See, any result below the LOB is considered non-existent, negative.
Mhm,
Okay?
mhm.
Because we consider this maybe an interference with the analyzer, maybe an interference with the light source. Maybe the analyzer is not that sensitive. So anything below the LOB is considered zero, non-existent. Okay? No reading. Between the LOB and the LOD, we cannot say we have bias or we have a precision because it's just a matter of detected or not detected. Okay, we do not work with the quantitative values. So bias and the precision are irrelevant here. Okay, we just say detected or not detected.
Okay. Yeah, very clear. Thank you. No, because
Okay,
I'm asking for the sample
yes.
doesn't matter because in the lab, of course, we're reporting as the detection, but
Mm,
I'm concerned about the the external quality control because some QC
mm,
that
mm.
external quality control maybe it is below limit of detection, so we are still releasing LOB, right? Whatever it is, but as long as we cannot get the concentration or sequence.
Yeah, between LOB, LOD, you don't give a concentration. You just give a present or absent. Between LOD and LOQ,
Okay.
you
Yeah.
may give a quantitative result, but you have to know that its performance in terms of precision and bias usually is very poor. Actually, the
Okay.
definition of LOQ is that anything above the LOQ falls within defined precision and bias qualifications or limits. Okay. So when you run the LOQ verification, if your samples do not achieve a certain level of precision and bias, we say no, the LOQ is not verified. We have to go a little higher to get better results. Understood? So
Perfect.
anything above the LOQ is your regular AMR and it must fall within the manufacturer specifications for precision and bias, or even if you can use some local regulations or otherwise. Understood?
Yeah, clear. Yeah. Okay. Thank you.
You're welcome, Julius. Any other questions or clear for everyone?
Oh, yeah. Other question I need to reserve it later, maybe when you finish your presentation, because this is
Of
related
course.
for the. Yeah. Okay.
Sure, sure. Thank you, Julius. Sure. For anyone else, anything, or should I proceed? Okay, so I assume then it's clear. Now, for calibration, which obviously is very relevant to everyone's work. Now, calibration in, before we go to the slide, keep things simple. Calibration is a very simple thing, okay? Of course, there are some complexities related to it, but before we go into the complexities, calibration is simply the following. The analyzer is like, a child that have never studied math. No one taught them math in any way, shape, or form. So it doesn't know what's 1 + 1. It doesn't know what 2 + 3 is. It doesn't know anything. So you have to give it this knowledge to be able to do this work, okay? So if you give the analyzer, for example, plasma, and you tell the analyzer measure the quantity of factor 8, and you give it the CK pressed, and you give it factor 8 deficient plasma, and you give it everything, it will do the test. It will get a clotting time of maybe 40 seconds. Now the analyzer will be as follows. Okay, I got 40 seconds. I don't know how to convert 40 seconds into a concentration of factor 8. No one taught me how to do it. No one gave me the information how to do it. Okay. For example, if you go to a CBC analyzer, okay, so the machine goes, aspirates the sample, does the dilution, adds the reagents, and in 20 seconds time, for example, it counts 300 RBCs. So the machine says, okay, in 20 seconds, I calculated 300 RBCs. I don't know how to convert this into cells, million cells per ml or microliter, for example. No one taught me how to do it. So calibration is very, very simply, you are teaching the analyzer how to convert something that it's measuring into something that we can report to the clinician. Because often the thing you are measuring on the analyzer, optical density, clotting time, lumens, for example, etc., etc., what the thing that the machine itself is measuring cannot be reported to the clinician, right? So for example, when you work with chemistry, a lot of time you are using optical density. Can you report optical density to the clinician? It has no meaning. So you have to teach the analyzer that if you see this thing that you are measuring for this reagent lot, for this parameter, for example, convert it using this formula that I will teach you to give me a value that I can report to the clinician or to the patient. This is what calibration does very, very simply. It teaches the analyzer how to convert the thing that it sees, the thing that it measures by itself, into something useful for us. That's why, for example, if you want to run antithrombin assay on our analyzer without calibration, okay, the machine will not do it for you because how will I convert optical density into something useful without calibration? You need to tell me that 0.3 optical density equals, for example, 60% antithrombin 3. 0.5 optical density, for example, equals 90% antithrombin 3. The job of the calibration exactly is this, to teach the machine, whatever it is, how to convert certain value that we cannot really use into another value that we can use, okay? So this is pretty much what I have just explained to you right now. This is the core of calibration. Everything else is just complexities related to how we do the calibration. So, for example, I want to convert the optical density values here, for example, that the machine measures, okay, into percentage values, because I do not all report antithrombin 3 in optical density. I have to report it as a percent because the reference ranges are percent. The relevant unit is percent for antithrombin 3. So what do I do in this case? I will get a calibrator. And what's special about the calibrator is that the calibrator has a known quantity or amount of the thing that I want to measure. So the calibrator, for example, in our case here, has 101% of antithrombin 3. Okay. For example, why did I not choose 67%? Because generally antithrombin 3 starts diluting from the concentration normal to the lower one. Doesn't matter. So I have a concentration in my calibrator of 101 for our example, let's say. I will make multiple dilution. One dilution gets me 67, one dilution gets me 34. If you see, they are all in 2 because we are running this calibration in duplicate. Each concentration is run twice. So 2 runs of original concentration, 2 runs of another dilution, 2 runs of another dilution, and finally the last 2 runs, I use a blank. Okay, why do I use a blank? Doesn't matter now, but I use a blank. Okay, so then I tell the analyzer, please measure the optical density for all of these concentrations, one by one. So the analyzer does the measurement. 101 gets you 0.596 optical density, etc., etc., etc. Then, how would the analyzer next time know how to convert optical density into a percentage like this? The rest is just simple math. I will use a formula, okay? Simple mathematics. I will use a formula that will tell me next time you want to calculate the concentration C of antithrombin 3, just run the test and you'll get optical density D, and then you multiply it by this number and then you add this number. Then you will get value in percent. Okay, so interpol percent is the actual calculated value from this optical density if we use this formula. Simple as that. Okay, so again, this column is how much is the value of percentage if you use this optical density and apply it in this formula, concentration equals minus 61, etc., multiplied by optical density D plus so and so and so. This is the value you will get. Okay, this is what calibration is. So I used something of known concentration to measure something that the analyzer is measuring, optical density per minute, which is useless to the clinician, useless to the patient, to convert it into known values or percentage values. So, okay, so pretty much this is what calibration is. Now, why do I have to run multiple dilutions? Because if I run one concentration and it tells me, oh, optical density is 1.1, 1.2, 1.3, okay, okay, fine. How about lower concentrations? How about the lowest concentration? I don't know. So maybe the machine has actually a very significant bias, but on this very single concentration, it reads perfectly well. You never know. Maybe at lower concentrations, it reads horrible results. But at this particular single concentration that you decided to run your calibration with, it was very bad. That's why often we do calibration on multiple points so that we detect, do we have a problem with lower or high concentrations? Because this can happen. Okay, so often calibration has to be done with at least 3 different dilutions or 3 different levels of the calibrator. We don't use just a single point often with calibration, okay? So, as I told you in the beginning, the whole point of calibration is just to teach the analyzer to take the input it generates into an output that we can make use of. Often this is the case that we need to convert unit, for example, in second to percentage in factors, for example, okay? But sometimes, for example, CBC analyzers or flow cytometers are the most prominent examples. Okay, I'm not converting a unit into another unit. I just teach the analyzer. What you are measuring in this window of time, for example, or something that looks like this actually means this much. Okay, I think the concept by now is clear. But this concept that applies to CBC and flow cytometers does not really apply to coagulation. This is the concept that applies to coagulation. I need to run multiple dilutions of something with a known concentration. So I would convert certain unit like optical density into another unit like percent. Why? Because optical density is meaningless for me clinically. This is pretty much the same thing we described. Now, here, please note something. Second paragraph. When a test is reported in ratio, like INR is a ratio, patient result divided by mean normal PT, the reference time, up to the power of ISI. This is considered a ratio. A ratio is not a different unit. Normally, you do not need a calibration for ratios. Normally, okay? So to report a ratio, often you do not need a calibration. Understood? Because a ratio is not a different unit. It's not something different. I already have the patient result. I already have the reference time. I'm not converting anything into something else. Understood? So no change in units, no new calculations, no nothing. I'm just dividing one result by the reference time. So that's it. Ratios do not require calibration. Small point. Someone might tell me, okay, but there are calibrated INRs. This is completely different. This INR calibration is simply to make sure that you are measuring INR as accurately as possible without having to go through the headache of MNPT and this and that and the ISIs and so on and so forth. Okay, it's a different point. So INR calibration is not the same principle that I was describing to you, basically. So what sets a calibrator apart from a quality control? Why can I not use quality control for calibration? Why can I not use a patient sample for calibration? I can go, for example, to a very good lab, excellent reputation. I'll tell them, give me a sample of factor 8. Factor 8 concentration in this sample is 90%. I will take this 90%. I will tell my machine, okay, factor 8 in this sample is 90%. Please do calibration considering that the concentration of factor 8 is 90%. Why can I not do that? Reason is very simple. Calibrators have assigned concentrations, but the way we assign these concentrations must be very, very, very accurate and must be generally traceable to an international standard. What do I mean with traceable? I'll explain to you in the next slides. But the concentration of the calibrator must be set very, very accurately. What guarantees you that this sample with factor 8, 90% from the other lab at that particular moment that machine did not have an issue? Maybe that lab doesn't work with the reagents very well. Maybe they don't have the best reagents. Maybe they did not reconstitute things well. You don't know. So there's a lot of uncertainty surrounding this patient result that you got from the other lab, which means that your calibration will not be accurate, which means the results you report to your patients are not good. So there is a high risk for your patients if you use a calibrator with a value that's not assigned very, very accurately. That's why calibrators are far more expensive than quality control materials. Okay, because the quality control materials do not have assigned values. They just have ranges. And to calculate these ranges is much cheaper than to give assigned values to calibrators. So the reason calibrators are expensive is because the work needed to assign to them target values is expensive. It's difficult. It takes time and effort and money. Okay. So then, how do we assign these values to calibrators? There is, for example, something called NIBSC. It's an entity that produces something that we call an international standard. An international standard is a plasma or different kinds of materials with assigned concentrations that are assigned in a way that is as accurate as we can possibly do. Okay, and these materials are produced usually in small batches and they're extremely expensive. You cannot, for example, go into an IBSC and tell them, oh, I want an international standard. Okay, usually these international standards are sold to an entire country where there are national calibration labs, or they are sold to manufacturers like Stago, for example. So Stago can go to an IBSC. I'm a manufacturer of coagulation testing, for example. I want an international standard for factor 8. They tell you, okay, here is a vial of factor 8 that is assigned factor 8 concentration of 90.334%. It will be very, very accurate. Okay. Then I can use this international standard. I will calibrate some machines that I have. I will calibrate the new calibrators that I have in my production. Then I will use these machines to assign values to the calibrators that I sell to the users. Okay, so there's the chain of calibration until you get your calibrator. All right. So in IBSC, the international standards they produce, they call them primary standards. That's the name that in IBSC gives to their international standards. They call them primary standards. Okay, that's them. That's their choice. So, for example, I go to NIBSC as an entire country. Sometimes some countries, they have governmental labs. They call them national calibration labs. That lab produces local calibrators for the manufacturers in the country. Some countries operate like that. So maybe, for example, if France says, okay, no, I want to have a national calibration lab, I will go to NIBSC. So NIBSC sells to France the national standard. France uses the national standard and sells it to a calibration laboratory. Okay, the calibration laboratory will go, for example, and sell to manufacturers to make their own calibrators. The manufacturer will use this calibrator to calibrate their production machines. Then the production machine later on, okay, will produce something for the customers, the STA unit calibrator, for example. Then the customer will calibrate their machine, for example, the user equipment. Then I will give you a result, the final product. So this link between my final result all the way to NIBSC or the international standard, we call it traceability because I can trace the calibration of this result to my equipment, to the manufacturer to the national lab or accreditation lab, this to the national calibration lab, to the international standard, for example. So we call this the traceability chain, okay? Traceability pyramid is just a name that they give in this photo, doesn't matter. Okay, so some customers will ask you, where is the traceability certificate for your calibrator? How do I guarantee as a user that your calibrator that you are giving me is actually traceable to an international standard? Why is that important? Because most manufacturers will use the same standard. Why? To reduce the variation in results between manufacturers. Because if every manufacturer makes their own standard, their own calibrator, you will see a huge variation in results between a machine and the machine. Factor 8 on one machine, maybe 30%, on the next machine, maybe 70%, and the third machine, maybe 5%. This means completely different diagnosis for the patient. So it's very crucial to have as many international standards for as many parameters as possible. Not all parameters have international standards, but there is really an effort to make as many of them as possible, because this reduces significantly the variation between machines, which significantly reduces the effect on the patient's management, their diagnosis, and so on. I mentioned to you this point. I will not talk about it more. So I run a calibration. Okay, how do I do the calibration? That's a part you see in the training. It's not the topic now. I run a calibration. How do I verify that my calibration is actually a good calibration? How do I verify that it's actually reliable? Maybe it looks good, it looks fast, but how do I know that it's actually good? Because a lot of times you run a calibration, it happens. You run a calibration, looks perfect, looks amazing, straight line, perfection. R value 1.000. You run a QC, everything fails. What went wrong? This is the point that we want to discuss. So, two main points. When I run a calibration, I have specific pieces of information that I can use to check, is my calibration good? The second step that you must do is to run the quality control. You have to do both of them. One without the other is not enough. Okay? So as you see here, both of these points that I mentioned to you, checking the calibration statistics and running the QC are important. Okay? And I have added for you one document that you can refer to remember these points. And you can share it with the user, feel free. Now, for example, this is the calibration for the antithrombin 3. What can I check from this? Now, the thing that most of you know to check is this R value. R value in the case of calibration is called regression coefficient, okay? Because sometimes R value is called correlation coefficient. It varies. Regression coefficient, okay, in this case, why is it called regression correlation? Not our topic at the time, but anyways, it's called regression coefficient. Regression coefficient for most parameters of a Stago should be 0.995. Does it matter? Minus, plus, doesn't matter, okay? It's just the direction of the calibration curve. We don't care about it for now. 0.995, or for some parameters, it's a little more. So this one, 0.999, perfect. It's higher than all the claims of Stago. Can I make sense of this formula that's used for the calibration curve? It's not very useful for us. Anyways, it's not meant for us to use. What else can I check? All right. Now, this is the assigned concentrations for the dilutions of the calibrator that I use. This is the optical density, and I cannot really do much with either of them. How about this interpolation? Now remember, interpolation, these are the values that we calculate from the optical density actually measured for this dilution when we use this formula. Okay, so if the interpolated value is very different from the calibrator value, means something is wrong, right? If, for example, the calibrator value here is supposed to be 0% and this one is measuring 20%, how come at zero concentration of the antithrombin 3, my machine thinks there is a 20%? Means when there is 0% antithrombin 3, my patient result will be actually 20%, which is completely wrong. So interpolated values should be as close as possible to calibrators. How close? There is no official cutoff, okay? But they should be as close as possible. So maybe 1, 2, 3 points difference should not be a big deal, okay? But it should be as close as possible. In our case, you see, 103 is not so different from 101, 67, perfect. 31 a little low, but not a big deal. 31 to 34, okay. 1 to 3, fine. I run the QC. The QC passes, yes. Case is closed, okay? How is my QC doing? My QC is doing very well, okay? So these are two very important points for me to check. Another point that may be very useful, QC is failing, calibration looks absolutely perfect. You can compare this calibration with the previous calibration, because sometimes you may have cases, maybe the user, for example, prepared the calibrator with 2 ml instead of 1 ml. Everything will be half the value, but the interpolation, everything will be half the value, but the R value will look perfect. So you think everything is passed if you do not look carefully enough. But the QC, everything will read at half the value. Okay, so if the R value passes perfectly and the QC failed, check the preparation of your reagents. Compare your current calibration report to the previous calibration report. For example, if you notice at the 100% concentration, previous report optical density was reading 0.7 or 0.6, and all of a sudden now I'm reading 0.2 or 0.3. That doesn't make sense. Usually reagent to reagent, Stago reagents are very consistent. Okay, so it doesn't make sense when your optical density or clotting time suddenly changed very, very significantly from one calibration to the next. That should not happen. Okay. So the R values, how do I know if it's acceptable or not? You said some parameters have higher than 0.995. As I told you, from Stago, most parameters, they should have a calibration R value that's 0.995 or higher. Exceptions are STA immunodiff 8, 9, and 11. They should read more than 0.998. Diskette ABP, it's a different manufacturer. I don't care about this one, okay? For STA liquid HIP, when you run the hybrid calibration curve, your R value should be 0.997, okay? Sorry about this. This is coefficient of regression. Sorry, regression coefficient. I will change this. My bad. Now, one small exception is when you work with von Willebrand RCO. The R value only for von Willebrand RCO. The R value should be 0.98 or higher. And by the way, do you see this in duplicate? This comes from the SOP of Rmax. Piece of advice we learned from experience in the field: do not run von Willebrand RCO calibration in duplicate. I know the SOP says so, but most likely your calibration will fail. Change the settings, change the methodology of von Willebrand RCO to single, not duplicate, for calibration only. Okay? It will be fine. Now, for von Willebrand RCO, you will see some descriptions here that if dilution 1 to 8, the difference between two measurements is 15%. This is if you run the calibration in duplicate, but I told you do not run the calibration in duplicate, please. It will fail. It is very likely that it will fail and you have to repeat it until the kit runs out, which is not very good. It's a very expensive kit. So this means if between the duplicates at 1 to 8 dilution, the difference between duplicate 1 and duplicate 2 is 15%, this is acceptable. But as I told you, we are not running duplicates. Forget what is this. I care about 0.98, okay, and I care about the QC. They are good, I am good. So RCO is a bit of an exception when it comes to calibration. So these are the points that we discussed, okay? So these are the things that you have to consider. And the point that I told you that the difference between interpol and calibration, this 10% is more or less comes from experience of people in the field. So it's not an official recommendation, but it's a good thing to use as a rough measure of how things are behaving in my calibration, okay? So is 10% something officially from Stago? No, but it's a good rule of thumb that this interpolation value should not be more than 10% different from this. I don't mean 10% like this is 11%, okay, this is acceptable. No. 10% difference. For example, what is 10% difference here? It's around 3 points difference only, not 40%, 41%. This is not what I meant, okay? 10% difference means 31 minus 34 divided by 34, that will give you a value of percentage difference, okay? Now, before I go into the notes, does anyone have any questions about calibration? Because of course, it's a very important topic.
Yeah, about the
Yes, Ibrahim.
calibrator. Can you explain why the measurement of uncertainty decreases down the line? I do know how, but if somebody asked me to explain, I don't think I will be able to explain it properly. So, yeah.
You mean the uncertainty measurement increases?
Yeah. The measurement of uncertainty from the primary standard all the way down from the manufacturer standards to the customer calibrator. It decreases, right? And from the customer calibrator to the sample results also the measurement of uncertainty decreases a bit, no? So why how come it changes like that?
Sure. If you may please remind me of this question at the end of the uncertainty of measurement section, so everyone will understand what exactly you are asking in this question. Okay? So people will have a concept of what uncertainty of measurement is.
Okay.
All right?
Okay.
Okay. Now, there are a few notes that are important for you to note. Now, if the user is using PT%, I know most of you, the users use PT second, but if you have a user that uses PT%, whenever you have a new lot of PT, you have to calculate the mean normal PT, or what we call a reference time. If the user is using percent, the reference time or the MNPT are also the 100% point. 100% what? We consider the reference time or the mean normal PT, same thing, to be 100% activity of a normal person, or that represent a normal person, an average person. So 100% activity of coagulation factors, okay? So if PT is 100%, means your coagulation factors activity is equal to an average person that represent 100%, okay? So if the user is using PT%, you use the MNPT or the reference time. And when you go to calibration, you will see the machine is asking you for a reference time and for 100% point. Both of them should be the same. Because again, the reference time is same thing as the 100% point. This point is important. Okay, so always when you change the reference time, you have to change the 100% point. Otherwise, your 100% values are not accurate. Okay, so it's very important that you do this. Now, when you work with antithrombin 3 on the max generation, you will see something called offset correction. Offset correction means you use orange color and run it again in the 0% point of the antithrombin 3. Remember the calibration curve that I've shown you for antithrombin 3? There was a assigned value of 0. That's actually not a calibrator. The machine is using orange color and we put it at 0 because there is no antithrombin free in orange color. Offset correction is something that you may need to use when the antithrombin reagent is sitting on board of the analyzer for 3-4 days, 1 week, because it's a very long stability reagent. The problem is if you do offset correction, when you load a new vial of antithrombin 3, you have to repeat it again. Okay? What is the advantage of this offset correction? If you start to notice that your antithrombin QC, as the reagent sits on board for multiple days, you will notice that the QC starts to increase or starts to decrease slowly. Then offset correction will help you with this issue, okay? Because evaporation from the reagent will affect the readings. But generally, from experience in the field that people report, it's not something that they recommend people to do. But if you see it in the calibration, now you know what it is, okay? So if you absolutely have to do it, do it. But remember, with the new vial that you load, the new vial that you reconstitute, you have to run offset correction again. Otherwise, your results will not be very accurate. Now, these reagents that you see in front of you, they have to be calibrated every time you want to run patient samples and QC. And pay attention. I said STA deficient 9, 8, 9, 11, and 12. I did not say immunodef. Immunodef factor reagents are stable for the whole lot. STA deficient reagents 8, 9, 11, and 12, they have to be calibrated every time you run a patient sample and you run a QC. And you have to immediately run the QC and the patient samples after calibration, immediately. Okay? This is what Stago tells you in the IFU. After calibration, instantly run the QC and calibration. Do not wait. The more you wait, the more unstable the reagent gets, the worse your accuracy gets. The same thing applies to stacklot protein S and the stacklot protein C. Do not confuse them with the stachrome protein C. Sorry, wrong, missing T here. Do not confuse the stacklot protein S with lyatest free protein S. I'm saying specifically stacklot protein C, stacklot protein S. Okay? You calibrate, you run QC, QC passes, immediately run your patient samples. Do not wait. Okay? This is what Stago tells you. Otherwise, a few hours later, results will be all out. Can I do this? Can I freeze the reagents? Believe me, you don't want to do it. It will not work. Now, this is the point that I mentioned to you earlier, okay? From a lot of painful experience in the field, Von Willebrand RCO run the calibration in single runs only. Duplicates will fail. Why? I tried to dig behind this information a lot and I didn't have any clear answer for you. Now, when you want to calibrate tests, especially when you are talking about factors, especially protein C and S stacklot, please make absolutely certain that you use fresh orange color, use fresh calcium chloride whenever they are needed, okay? Do not use old orange color and calcium chloride, especially for protein C and S. They are very sensitive, okay? Factors are less sensitive, but they will still fail if you use old orange color and old calcium chloride. Stacklot protein C and S are especially notorious for failing if you do not maintain your machine well before you run them, if you do not use fresh reagents, if you do not take care of your machine and it's just sleeping there, no one is doing daily maintenance, no one doing weekly maintenance, you will not have a good time with these reagents. So advice is, when you use stacklot protein C and S, okay, do the maintenance before you run them. Make sure you use all fresh reagents immediately after calibration, run a QC and patient samples. Otherwise, you will have another very pleasant time with these two, I promise you. Any questions before we move to uncertainty of measurement, which will be the last section, I believe?
I have one question, Laith, please.
Sure.
According to stachrome protein C and S, we have to do calibration also every run or every lot?
Stacklot, you mean?
Stachrome.
Stachrome protein C every lot. There is stachrome protein C, no stachrome protein S.
Protein C only, sorry. Every
Yes.
lot?
Every lot. Now see, except these 6 reagents, everything in Stago is once per lot. Everything. So these 6 are the exception. Now, the deficient line of reagents is pretty much dying. I don't think they are commercially available for you to buy anymore, but if they still are, it's good for you to know. Okay, so you will not fall into the issue that the customer starts to complain, the stability is not good, I have to calibrate all the time. This is the norm. Okay, so
Okay, thank you.
anything else, once per lot. You're welcome. Any other questions?
Hello, Light.
Hello, Mahmoud.
Yes, so I believe like you remember a lot of sessions with me regarding protein S stack lot, and
Very vividly,
alhamdulillah,
yes.
like we were able to figure it out by just newly auricular and calcium chloride. Their weekly
Yeah.
maintenance was like, what we can say, it was scheduled for another day as compared to their the day on which they are running their batch. So we
Mhm,
actually never did this on the same day, like the weekly
mhm,
maintenance. So I just wanted to ask that, do I make like internal SOP for myself when I am training the customers or so, that if
mhm,
another customer wants to be shifted to stack lot S,
mhm,
so
mhm.
I can ask them to maybe align the day on which they are running their batch to their weekly maintenance day. Would it
Preferably,
be a
see,
better?
to give you more details. Yes, to give you
Yeah.
more details. For protein C and the protein S, the most important factor I would say in failure is that reagents are old, or maybe
Yeah.
not reconstituted properly, for example, and the machine is very old and not maintained. Now, of course, some machines are in better conditions than some other machines. Some machines are less busy than some other machines. And one point that I think would be quite good to follow is try to run protein C and protein S by themselves. When you are running routine, finish your work, dedicate some time to finish protein C and S by themselves. Do not run anything else with them. Then continue the rest of your work. Okay. The reason is protein C and S are very, very sensitive to incubation time. So if the machine is very busy and the machine has to handle a lot of qubits in the incubation area, you might have slight delays on the incubation of protein C and S. And I have seen cases where this causes the calibration to fail or your QC to fail. So ideally, do the maintenance before you do the calibration for these two. Make absolutely sure you use fresh reagents and immediately start after you load them. And do not run these calibrations and the QCs of protein C and S, even the samples, along with other routine or even specialty assays. Give them some time for themselves, finish working with them, and then move on. This should give you ideal results because, again, some machines are older, they are more used, they are more worn out. Some machines are okay, so you may not notice as many issues. But to avoid as many issues as possible, because this is a very expensive kit, you have a small amount, better be prepared as much as you can.
Exactly. Thank you so much, Light. And
You're welcome,
really,
Mahmoud.
as we found out in in most of our troubleshootings, like it was the particular timing. Like sometimes they were using old controls and their controls were not passing, and sometimes like they were giving some extra time after reconstitution before they load the
Yes.
reagents. So yes, thank you so much,
Uh,
Light.
you're welcome. Believe me, we learned this the hard way.
True
So
that.
yes, uncertainty of measurement. Now, uncertainty of measurement might sound like a complicated concept. Uh, some of you who are involved with CAP may have heard about it from the customer that what is uncertainty of measurement for this test? What is uncertainty of measurement for that test? Now, to simplify, it's not something complicated. Uncertainty of measurement very simply tells you or is how unsure I am of my result. For example, I want to report factor 12 to the clinician. The machine gave me 80%. How sure I am that this 80% is not really 85%, but the machine has a little bit of bias or has a little bit of imprecision? So how sure I am? Because I should have some information that maybe my machine is accurate, maybe my machine is not accurate. I can report from it, I cannot report from it. Uncertainty of measurement answers this question. So uncertainty of measurement tells you that when your machine, for example, reports 80%, 80% can be actually anything between 78% to 82% in the actual patient sample, okay? So again, uncertainty of measurement tells you that if you see this number, most probably this number is anywhere in between this much to this much, okay? We cannot be 100% sure because, of course, we can never be 100% sure with the measurement. But your uncertainty of measurement is little, so you can report this result with confidence. The difference from what actually is in the patient sample probably is not very big. So probably it has no impact on the patient. This is what uncertainty of measurement tells you. But for example, if the machine reports to you 80%, but uncertainty of measurement is very big, meaning uncertainty of measurement tells you that maybe this result in the patient sample is anywhere from 60% to 100% in the actual patient sample. If it's 60%, it's something. If it's 100%, it's something completely different for the patient. So this is a huge amount of uncertainty about my result. I'm not so sure of my result. Means if I report it to the patient, it might alter their clinical management. It maybe affect the patient negatively because I'm not so sure. Okay, so uncertainty of measurement tells you how sure are you about the result. So it's important, for example, for the clinician, if possible, to have uncertainty of measurement reported, so the clinician will know, oh, okay, this test uncertainty of measurement is very small. So even if the result is a little bit biased or a little bit imprecise, it probably will not affect the patient result. Okay. So uncertainty of measurement is really a different way or a different concept, a different way of expressing the total analytical error. Remember what we were talking about yesterday? Total analytical error is a way to estimate the amount of bias, the amount of imprecision that I have in my measurement. Okay. Uncertainty of measurement is something very similar. So uncertainty of measurement gives you an estimate of how much bias, how much imprecision is in your measurement. So they are two different terms that describe pretty much the same idea. Okay. So is there really a difference between uncertainty of measurement, total analytical error? Pretty much none. Okay. It's just that some people believe that you can calculate it this way. Some people believe that you have to calculate it this way. So this is for people who are very experienced in the field of biostatistics. It's not our concern at the moment. Okay. But essentially for us, total analytical error and measurement of uncertainty tell us the same idea. How much bias, how much imprecision we have in our measurement. Now, again, why do I care about telling you about this uncertainty of measurement? Because now there is an increasing need by users to know what is the uncertainty of measurement for my test, especially the ones who have CAP accreditation, okay? So this is pretty much what I explained to you. So to simplify, if X value was the 80% measurement that I told you about, okay? Uncertainty of measurement is this yellow area. Yellow here, okay? So 80 plus 2, for example, and 80 minus 2, for example. So I say my uncertainty of measurement is plus minus 2 when you are measuring at 80%. Okay, so your measurement can be anywhere 80 minus 2, 78, or 80 plus 2, 82. So your measurement can be anywhere in this area. This is what I mean with uncertainty. I'm not certain that my measurement is 80%, okay, but I'm sure with a good degree of confidence that it falls between 78% and 82%, which is clinically not bad. It's very good, for example. Okay. But if the uncertainty of measurement is very wide, my machine is measuring anywhere, or the actual concentration can be anywhere from 20% to 150%. This is very unacceptable because the actual measurement can be anywhere between 20 and 150%. This is a completely different readings, can be completely different for the patient, completely different for the treatment of the patient. Okay. So if the uncertainty of measurement is a certain value, then you can see the true value, the actual concentration of the sample falls within the range of the uncertainty of measurement. This is what we mean. Okay. And for us, we say this is acceptable. Okay. So how do I calculate this uncertainty of measurement? Now, there are many different ways and things can get very complicated very quickly, but I told you the whole point of this presentation is to simplify things for your practical use as much as possible. So the best way that is currently available that most people that work in the lab use is you calculate the monthly standard deviation of your QCs. Okay, so I calculate the standard deviation of my QCs, normal and pathological. I calculate the standard deviation for the normal QC, put it aside. I calculate the standard deviation for the pathological, put it aside. Then I multiply the standard deviation of the normal QC by 1.96. Why not 2.0? 2.0 actually represents 95.5% of your population. Okay, so some people who like to be very specific, they say 1.96 represents 95% of the population. Why 95%? Not our concern at the moment, okay? So I take the standard deviation of the normal control, I multiply it by 1.96. I take the standard deviation of my pathological control, I multiply it by 1.96, okay? So I say that uncertainty of measurement at around this concentration, which is the concentration of the normal, is this much. The uncertainty of measurement at around this concentration, which is the one for the pathological, is around this much, which is the 1.96 multiplied by standard deviation. Okay? And this is to be done every month. Now, this is an example that just uses numbers and dates for you to understand what I explained to you in the previous slide. So I will skip this one. You can read it by yourself later on. Now, what I was telling you is you take, for example, the normal QC and you calculate the standard deviation over 1 month. This one standard deviation is called uncertainty of measurement. Okay. The 1.9 SD is called expanded uncertainty of measurement. Why expanded? Sounds fancy. It's not fancy at all. Uncertainty of measurement is this much. Expanded uncertainty of measurement is this much. That's why you call it expanded. Okay. So because uncertainty of measurement is 1 SD, expanded uncertainty of measurement is 2 SD. So it's just bigger, it's expanded, it's stretched. That's why we call it expanded, okay? So nothing fancy. So expanded uncertainty of measurement means 1 uncertainty of measurement multiplied by 1.96 SD. Again, why 1.96? It represents 95% of the measurements, let's say, without going much further into this point. Okay, so this gives you a small example. So we get this standard deviation from March, etc., very much similar to this example, okay? You can read it by yourself later on. This is pretty much how labs work with this kind of, with the uncertainty of measurement and how would you work with it. It's very simple. Now, as I told you, there are more complicated methods that would use, for example, your recast results, your Qualys results, your cap samples results. They will also integrate your calibration uncertainty of measurement that is available in the traceability certificate into your measurement of uncertainty. Okay, but we don't want to go down that rabbit hole because things can get very complicated very quick. So as I told you, for purposes of practicality, a lot of labs, this is what they practice, and this is what some guidelines tell you to use for sake of simplicity. Because of course, the more you complicate things, the more likely the errors are to be in the lab. Now, there is one major issue with measurement of uncertainty. There is very poor standardization for what can be used in the field. Plus, to actually calculate the uncertainty of measurement for the entire analytical measuring range, you should have samples that span all the analytical measuring range. So maybe I need 20, 30, 40 samples, and I have to calculate the standard deviation for them every month or every few months. For all of these 40, 30, 20 samples, for example, that span the analytical measuring range, as you can imagine, this comes at a huge cost to the lab. So it's very difficult to do. That's why, for example, if my normal QC measures at 100%, my pathological control measures at 20%, what is the uncertainty of measurement at 50% readings? I don't know. I have to get a QC that says 50%, calculate the SD over a month by running it over an entire month, and then I calculate the uncertainty of measurement. So this is one gap with this kind of calculation of measurement of uncertainty, as you can see. Okay, so it's not a perfect approach, but it's one of the approaches available. As long as the customer will ask it of you, then you have to know how to deal with it, okay? Because sometimes it's a requirement of accreditation. This is the point I just mentioned to you. And the reason we normally use a QC for the uncertainty of measurement and not patient samples, simply because normal patient samples are not stable enough for an entire month for you to calculate the standard deviation of them. Simple as that, okay? I know that quality controls do not exactly represent patient samples, but we don't have much of a choice in this case. It's a matter of an issue of stability of the patient samples. I don't think there is much to discuss here. This is the point that I just described to you, that the uncertainty of measurement usually is for specific points and not the points in between them. Now, back to your question, Ibrahim. Ibrahim was asking, if you guys remember, when we went to this slide, I will show you that slide. This one. If you look at this arrow, it says measurement uncertainty is getting bigger. So as you go from the international standard all the way down to the patient result, measurement uncertainty is increasing, which means the possibility of error is increasing, right? This is what measurement uncertainty is, how unsure I am about my result, which means there is higher and higher error as we go down this traceability. The reason is, with international standard, the amount of error expected is very, very tiny. That's why I told you it's assigned with very accurate methods, and generally it's very expensive. Why? To reduce the error as much as possible. So with the international standard, your chances of error are very, very tiny. But when you take this international standard and run it in the national calibration laboratory machine, the machine itself, of course, is not 100% accurate. So this adds a bit more error to the measurement. You take this new calibrator that you made in the national calibration laboratory, take it to the manufacturer. The manufacturer machine is not 100% accurate. It adds a little bit of error. You take this calibrator you produce in the manufacturer lab, you run it in the lab itself, the customer lab. The customer lab, the machine in it is not 100% accurate. So this adds even more error on top of the error that came with the calibrator already. So every layer adds more error to the measurement. It adds more uncertainty. We are more and more uncertain because every machine, every step adds more possibility of error, because machines are not perfect. Humans are not perfect. Okay. There is always a bit of error that is added. So the more you go down the chain, the more is the uncertainty of measurement. Okay. Does that answer your question, Ibrahim?
Yes. Thank you.
You are very much welcome. Now, we will wrap this up with a few notes that may be useful for you. Now, when I want to evaluate my precision, when I want to evaluate my comparison, when I want to evaluate whatever it is, what are the guidelines that I should use? What are the documents that I should use? Now, CLSI tells you there's a hierarchy of sources of error, so to speak, or sources that tell you the allowable limits of error. It's not this, okay? This is not what I used. I did not use CLSI. This is what you would practically normally do in the field. CLSI tells you should use the clinical, or what the amount of error that's acceptable that does not leave a clinical impact on the patient, but that's very difficult to estimate, etc., etc., etc. Okay, so what's in CLSI is different from what's practically applicable in the field, and they acknowledge this, by the way, in their documents. So in the field, what do I do? When I have installed a new machine, I want to verify the performance. What documents should I use? What total allowable error should I use? What limits of bias should I use? How do I verify my performance? First source of acceptable performance is the manufacturer claims. For example, the SAV 4012, the correlation claims of Stago, the ones used for comparison. If you do not have that, then you can also look for the local accreditation requirements. Some countries, for example, like UAE, they have local accreditation requirements. For example, they tell you the PT acceptable imprecision, for example, is 5%. Okay, so then you can use this. You don't have that, then you can use your accreditation requirements. For example, you are a CAP accredited lab. CAP itself has certain performance acceptable criteria. They tell you if the manufacturer did not offer you criteria, then look for local accreditation requirements. You don't have local accreditation requirements, CAP tells you, okay, use what CAP offers you. CAP does not offer you, look for other resources, which are, for example, published literature and guidelines. CLSI, for example, offers that. ICSH offers that. Sometimes RCPA offers that, etc., etc. Sometimes you have performance criteria that are provided in different countries to the one you are living in. For example, CLIA is in the US, RCPA is in Australia, Reliback is in Germany. Okay, so you can resort to these ones. So you go to the first, you don't have it, you go to the second, you don't have it, you go to the third, you don't have it, you go to the fourth. Now, this is not it's not holy scripture. Things can be done differently in different countries. It depends sometimes on the customer. Sometimes if the customer is very well informed about these points, maybe they would like to follow the CLSI, even though that can be difficult. Okay, but this is what is mostly followed in the field for practical reasons. Okay, does that mean this is 100% correct? I cannot say yes, but this is what most of the time is practical and efficient to use. And sometimes cost can be prohibitive to do some things that are mentioned in CLSI. And again, they acknowledge this and they know it. So what are the documents and tools for each of the procedures? Okay, I mentioned this to you. This SEV, so and so, this is the number of the document. This is the name of the document internally for Stago. But I labeled them for you and I gave them to you on the WhatsApp group. And they are all labeled with these names, so you can use them. Okay. Now, this doesn't mean that the tool will calculate things for you, with the exception of the biological test sheet. It will calculate and it will give you pass or fail. These documents will just guide you on what to do and what are the claims that Stago offers. Okay. It doesn't calculate anything for you. The same applies to complex precision. It's the same document, and the same applies to comparison. Linearity and DMR verification, Stago does not offer you anything to do this. Okay. So it depends if you have local guidelines, if you want to follow CLSI, you want to follow what the customer is normally doing. There can be a million ways, but that's a story for another day. If you need to discuss this further, please let me know. I'll help you with it. For carryover, we have two things, as I told you yesterday. Reagent to sample carryover, the biological test sheet will do this for you. Sample to sample carryover, as I told you, remember, one reagent, two samples. This document, which is labeled and I have given it to you, tells you what to do. So we use one normal sample, one hyperonized sample, and we run this experiment. Reference range verification, we don't have documents offered from Stago. Okay. However, the COAG expert, if you have it, it has a part of it that allows you to do this work and gives you all the statistics. It's really very good. Okay. So you can do, Ibrahim, if you remember what you were asking me, if you have historical data that you can use, COAG expert can do that for you and filters things very well. The only missing part is you do not have the patient information. Okay, you must bring that from the LIS that the patients do not have any pathologies, because often the LIS does not send this information to data managers. Analytical performance, I have to change that. Sorry, that's detection limits. Detection limits, we don't have anything generally offered from Stago for this. Okay. Finally, calibration. As you know, the calibration is done by the analyzer. It's calculated by the analyzer, so you don't need any tools for that. You just need the guide that I provided to you also on how to evaluate the calibration. Uncertainty of measurement, again, nothing is offered by Stago, but COAG Expert Accreditation Tools module allows you to calculate uncertainty of measurement. However, it uses your QC data, the standard deviation from the QC data, and it can use either the uncertainty of the calibration materials that we have. If you need this, I can offer it to you. Or you have the choice to use the uncertainty of measurement that comes from your external quality control materials, whether it's CAP materials, recast, ECAS, NECAS, whatever it is. As long as you have external external quality control, proficiency testing, then you can use the uncertainty of measurement module on COAG Expert. If you don't, you can use the calibration. But you have to have either the calibration uncertainty of measurements or the proficiency testing reports that come from Qualers or otherwise. Okay, and this is what I mean with guides only, this stuff. So guide only means you cannot calculate from this document, but it gives you guidance on how to do things. And this is, I think I repeated this slide. Yes. Sorry, I modified the previous slide and I forgot to delete it. Apologies. Usually the last resort, if you do not have performance criteria from RCPA or others, is you really have to go look for published literature and what some other authors have used. But this is the weakest kind of guidelines that weakest kind of acceptable performance criteria that you can use. Okay, because usually one lab does not represent everyone else, does not represent the performance of the analyzer or the reagent, but sometimes you really have no choice. And that's it. Do you have any question about this last section or question related to any part in general? So should I assume that things are clear for everyone?
Highlight. I
Yes,
have
Julius.
only for clarification. This is yesterday.
Mhm.
Remember you says about the CLIA and the total allowable
Mhm.
error. You said that it's very
Yes.
difficult. So, as what I understood, example for CAP or data innovations, like
Mm.
we have a CLIA guidelines or RCPI. Like when we say it's written there 15%, 8%, or in seconds, 8%, you
Mhm.
said half 50%. So meaning to say if 15%, so we need to put 7.5. Can you
Mm.
explain further that we need it half?
That is if you are trying to estimate, or if you are trying to know the amount of systematic error allowed out of the total allowable error. Okay. TLSI
Okay.
tells you that if you want to know what is the systematic error allowable for you and you only have total allowable error given to you, then systematic error generally is given a budget of 50% of the total allowable error.
Oh.
Random error is usually given a budget of maximum of a 25% of the total allowable error. Okay.
Okay. Because see, it's written what are
Yes.
the given like 15 or 20. So we always have, if we want to see the total allowable, so it should be always 50%. So regardless of percentage, like if 20, so we
No,
make
no,
it
no,
10.
no, no, no. Total allowable error can vary a lot, but as I told you, the budget of systematic error is 50% of the total allowable error given to you, whatever is the total allowable error.
Okay. I got it. It's clear.
Okay,
Okay.
but that's as a maximum. For example, if you do analytical or calibration verification, analytical measuring range verification, CAP calls it CVL, the calibration
Mm.
verification linearity. For example, for that, you would use the 50% of total allowable error, because when you do linearity and calibration verification with the linearity materials, you use systematic error budget. So you would use 50% of the total allowable error, which would be, for example, 15% for some parameters from CLIA. Maybe it's more or less from RCPA. Maybe it's something different from CAP. Okay. So these small details can vary, and then I know they can be confusing, but you have to deal with them on case by case basis.
Mm-hmm.
Okay,
Okay.
but the rule is in general, systematic error budget is 50% of the given total allowable error. Okay,
Okay, thank you.
you're welcome.
Second one,
Hmm.
remember, this is a follow-up question regarding maybe a few minutes back, I asked about the
Yes.
LOB. See, my
Hmm.
follow-up question about the LOB, yes, we understand about the bias and imprecision. Now, is there
Hmm.
any chance like any result of LOB which is we reporting as negative? So there's a
Hmm.
chance the sample that we can concentrate. We need to add more sample in there. We will get added to the maximum EMR. Any result which is LOB.
That's
Yeah, yeah.
yes,
Again,
yes,
I
that's a
will
different
clarify
story.
it
Yes.
again. I will clarify it
Hmm.
again. See, any result which is LOD, like I been above EMR, we dilute, or like it's for EPTT, we run for factors, whatever. But any result which is with OD results, so we're diluting it.
Hmm.
My question about the LOB, I mean the low limit. So see, first
Hmm.
run negative, we release as negative. So the question is, can we allowed or recommend to make it concentrate, meaning to say, add more sample?
This really depends on the test you are working with. Not all tests you can do this for. You have to validate that this is acceptable. For example, when you work with factor assays from Stago, the default dilution is 1 to 10. Sometimes if you
Mm-hmm.
detect that the dilution, the measurement, sorry, is below 3%, for example, the machine will do a 1 to 2 dilution. So you're concentrating the sample. But
Mm-hmm.
if you are working, for example, with a plasma that's not diluted, and in the first time the machine told you the result is too low, you cannot concentrate the plasma anymore. It's already normal plasma, right? So for some tests also, this is not acceptable. Maybe, for example, the interaction between the reagent and the plasma or whatever is you are measuring, whole blood maybe it's not correct. Maybe it will alter the way the machine is measuring. So it really varies test by test. I cannot tell you, yes, it's applicable for all tests. It really varies. For some tests, it's not applicable. For some tests, it's not acceptable. Okay, so
Oh,
this you have to know this test by test.
okay.
Okay.
Okay. Yeah, thank you. But I think it's written, hopefully it's written in the guidance in the APU that if we can or do we have any checklist like
In
which
our
test,
case,
like we
in our case, it's not relevant. In our case, you don't have to worry about the LOB at all. But for maybe for molecular biology, that's relevant. For drugs of abuse, that's relevant. For tumor markers, that's relevant. But this is none of the stuff
No,
that
I
we
mean,
work
what I'm
with.
saying is any result which is which not what I yeah, we have EMR and we have say, which is my concern is any result which is below, we're releasing directly with negative. So any result negative, this is my question again. Any negative results, as you said, there are some tests that we can do concentrate, right? We can do concentrate. That I'm
Sometimes it's
correct? Or can
applicable,
you please
yes.
correct me if I'm wrong?
Yeah, sometimes you have to know test by test.
Okay.
I
So do
cannot
you
give you a general answer. It depends on the test, really.
okay.
No, I
Okay.
don't have a guideline that tells you for this test yes, for this test no. Because
Okay.
this matter gets very technical and you cannot generalize because immunoassay stuff is something, fluorescence is something, immunochemiluminescence is something. You cannot generalize over all these things. You have a million different technologies and tests. No one can give you one answer. No one.
Oh, okay. No problem. Thank
Okay.
you. No problem.
You're
Okay.
welcome. Any other questions before we conclude? Okay, great, Radhi. Okay, then I think at this point we can stop the recording. Again, thank you everyone for your time, and it's good to get the time to talk to you after a while. If you